So the first thing we're going to start with is assessing the PA glide of the mid-thoracic vertebral segments. What in the world is a PA glide? So posterior to anterior movement of the superior vertebrae on the inferior vertebrae. So when we talk about segmental movement of the spine, we're talking about movement from top down. So how the superior segment is moving on the inferior segment. Okay? So go ahead and lie down for me. C7, T1, T2, T3, T4, T5, T6, T7. So the spinous process of T7 on this is midline or just about level with the inferior angle of the scapula. So T7 spinous process just about level with the inferior angle of the scapula. So, okay, so I'm gonna locate that on her. All right, so inferior angle, right, of the scapula, right? I'm gonna come straight across. So I'm using anatomical landmarks to identify, all right? So inferior angle, now spinous process. So now what I have my index finger on the transverse process of, I'll work my way up just a little bit. I gotta work up a little bit because the spinous processes of T7 is level with the inferior angle of the scapula per se. So I'm working up a finger width because we know that the thoracic spinous processes slope downward, right? So now I feel comfortable that I'm on T7. So my right index finger is on her left transverse process of T7, and my ring finger, not my ring finger, my middle finger is on the right transverse process of T7. So I'm on the transverse processes of T7, right? So now I'm gonna start off by just assessing. So I'm gonna take the ulnar border of my left hand, all right, and place it on top of my index finger and on top of my middle finger. And I'm gonna apply, ooh, she's stiff. That's probably why she volunteered. It feels like a brick wall. It feels like I can't, but I'm gonna see what I can get. I gotta apply a lot of force. Okay, so I'm assessing her T7 on T8 posterior to anterior on intervertebral motion. So some refer to it as IVM, intervertebral motion. So passive intervertebral motion is what I'm assessing right now, PA glide. Very simple. Not much at all. I'm gonna lower the plinth. All right, there we go. Now I can get a better assessment. So I critique myself, so I lower the plinth. All right. Now, what I'm going to do, I wanna assess her, I'm gonna go up and move up and assess T7 on T6. And I'm on both transverse processes. How do you feel? Stiff. Feel stiff? All right, I'm moving up. And you can map this out. So I'm almost like in her mid-scapula, mid of both scapulas now. T5 on T6. Ooh, with that assessment, I got a little release. Heard of audible release. So come right here, comes the teacher. Start from C1 and count down to T5. Let's see where we land. Let's see if we're in the same area.
Oh, you said T1.
Count from C1.
Oh, C1. Okay, C1.
All the way down to T5.
5, 6, 7, 1, 2, 3, 4, 5.
Yep. So if you come look where I'm at in orientation with her scapula, that's like where I am.
Mm-hmm.
Yeah.
Yeah.
So that's why I told you to do that, because I'm working my way up a finger, about just about a finger's width, and working my way up, and that's how I know where I'm at. So always use anatomical landmarks if you're not for sure. Yes.
Can you say the placements of your right fingers, like where they're at?
So good job. I'm glad you asked that. So my right index finger is on the left transverse process of T5. So my right index finger is on the left transverse process of T5. My right middle finger is on the right transverse process of T5. Then I take the ulnar border of my hand and place it on top of both, and my index finger and my middle finger are serving as dummy fingers. They are there to help, and I'm applying the force with my left upper extremity, almost like with my body, because I'm just leaning into it. So I'm using my body, I'm using an anterior or forward weight shift as well to assess that. Now, she has a little bit more mobility as I move up. Her mobility is increasing as I move up. I get more play. Do you feel the difference? As I move up, I'm getting more of a PA glide. All right, I'm going up now. T4 on T5. I'm just working my way up, assessing, seeing where she's maybe more restricted. So again, okay, working my way up, because I started with using my anatomical landmarks. Remember, I started with the inferior angle of the scapula, and we had the transverse process, not transverse process, the spinous process being level with the inferior angles of the scapula, and then I worked my way up about a finger's width to be on the transverse processes, because the spinous processes are angling downward. Okay.
If that doesn't make sense to you, look at it on the spine. It'll make a lot more sense.
All right. I'm about up at T3, T2 on T3 now. I'm working my way to T1 on T2. Right here, T1 on T2. A lot of people have problems at this C7 T1 junction. Okay, so now I can turn it into treatment once I assess it. So I can go to the area where I thought she had more problems. I thought she was, from my assessment, from what I felt, she was most limited T7 from what I said so far. T7 on T8, T6 on T7, and T5 on T5 on T6 started to improve as I moved up. So now, what can I come back and do? I know that that's a problem, okay? So now, she could be limited in rotation to either side. So say she's limited to rotation either side, and the patient feel like, oh, I just feel stuck in this area, or I feel like it's pulling in this specific area. That could be an area that could be entrapped or just hypomobile. The patient hasn't been moving, haven't been doing any functional things that require that particular motion. So I'm gonna go back. So now I gotta give you some important information. You may wanna make sure you write this down. So I'm assessing the PA of T7 on T8, right? So if I do a PA, a T7 on T8, what does that help to improve? What motion can that help to improve with T7 on T8 PA? Forward bending. All right. So the PA is necessary for forward bending of T7 on T8. So if I'm mobilizing T7 on T8, the PA, and I turn it into a treatment, I'm trying to improve forward bending of T7 on T8. All right. Now, if I want to improve backwards bending of T6 on T7, where would I perform the PA? On T7. So the PA of T7 also improves backward bending of T6 on T7. But I'm doing the PA at T7. Well, why is that? Yeah, because T6 is gliding backwards. Make sure that you know that and command that. That's National Physical Therapy Exam content. So make sure you know that if you mobilize and do a PA of T7, it's improving forward bending of T7 on T8, and it can also improve backwards bending of T6 on T7. We got that? Okay. So now, all right, what can we do, Dr. Carter, for treatment if we identify that? So first of all, what's gonna lead you to assessing this is when you look at, when you assess the patient, and you may assess active range of motion, right? You may take out the goni and do thoracolumbar side bending or rotation, or you may do, have the person do forward bending, or you may have the person to perform forward bending in conjunction with rotation, just to see what they report. And based on what they report with those movements, it may direct you to performing the passive endovertebral motion testing at whatever segment. Okay, so now I come back right here, and I haven't gone down below T8 just yet. I'm just sticking to a specific area for teaching and learning purposes. All right, come back right here. I come back to T7 on T8. Now I can just turn this into a treatment. Just gentle springing, okay? Now I can spend some time here doing this, okay? So I can try to get her as far as I can. So say if I get her to her grade 4, then I could try to oscillate right there between grade 4 and 3. Okay. And then after, just see if that improves treatment. Okay. Now, do you have osteoporosis or anything like that? No? So, I would use others for other purposes. So, no child expectancy?
No.
All right. Okay. So, no child, no osteoporosis, no active cancer. Okay. So now I did a grade 3, grade 4. I can still do grade 1s. Remember your gradings? All right, this is grade 1. I'm not doing much at all. Do you feel it? But that's a grade 1, then I go grade 2. You feel the difference? Grade 3, feel the difference? Grade 4, as she's at the end, this is as far as she can go. You feel that? So now I got a grade 3, and then I can oscillate. I'm keeping the oscillations between 4 and 3. You feel that, Dominique? I can back off of it and go 2. Did you feel that? But you gotta kind of get a feel for this. It takes practice. I don't expect y'all to be perfect with this. It's just giving you an idea. All right. Now, can I do a grade 5?
Yes.
Tia said yes. All right, take a deep breath in for me. Deep breath, deep breath, deep breath, deep breath. Blow out nice and slow. Blow out nice and slow, nice and slow, nice and slow.
Oh.
Then grade 5. Mm-hmm. Yep. So that woke her up. She's woke now. All right. So that's with the PA. All right. So I treated T7 on T8. I did some oscillations. I'm gonna go. I felt she was limited also at T6 on T7. I'm gonna go up, just kind of treat it. She's T7 on T8, T6 on T7. Yeah, she's still. So. All right, take a deep breath in for me. Blow out nice and slow. Nice and slow. There we go. Got a little release there.
Are you waiting for her spine to go neutral, or?
When she's exhaling, I'm basically waiting for her to become less guarded
Okay.
and her muscles to relax and give. Yeah. Okay. So we're gonna take it slow. We're not gonna rush through this because this is gonna be on your practical. So if we have high expectations, we want to spend time on this. This is foundational. So could this also improve rotation?
Yes.
How so?
Because rotation left would be an anterior movement of the right foot.
There you go. Good. So that's what you gotta be able to explain. That's good, Self. So when you get on the lab practical and you get a technique that says limited rotation right of T5 on T6. Okay. So you can do that technique to help improve that. You just gotta know why and explain it like almost like what Seth just did. You see? So there are some cases that students get tripped up on, but they're very simple cases that you can address with just understanding of orthokinematics, biomechanics. All right, very simple. So go ahead and practice that technique before you get shown the other one. So we just did a PA of both we did a PA utilizing contact through both transverse processes. All right. So now we're gonna do assess rotation through contact of the transverse processes. But there's a catch. Okay. So with the mid-thoracic rotation via the transverse processes, we're gonna apply the rule of the lower finger.
I just remember it because I remember reading about it.
Good. We're gonna apply the rule of the lower finger. Liz remembers it because she remembers reading about it. That is great. So right now, I've located T5. So this right here is the T5 spinous process. Okay? So if I want to improve T4 on T5 rotation, I have to get the setup according to the rule of the lower finger. I have to get that set up correctly to improve rotation. So the rotation of the superior segment is going to be to the side of the lower finger. I'm going to repeat that again. The superior segment that is rotating on the inferior segment, the superior segment rotation is going to be to the side of the lower finger. So what are you talking about, Dr. Carter? So this is T5. So I will put my index finger on T5, right? And I'm gonna put my middle finger on T4. So I'm gonna be even more specific. Be more specific, Dr. Carter. So my index finger is on the left transverse process of T5. My middle finger is on the right transverse process of T4. And I want to assess and or treat rotation to the left of T4 on T5. Because it's rotating, T4 is going to rotate to the side of the lower finger. And so my lower finger's on which side? Left side. So this is what's going to happen. I'm gonna show you what's going to happen. So as I apply, look at my fingers that I'm grabbing. As I apply a PA to this finger and a PA to the finger right here simultaneously, this is what we get. So T4 is rotating left on T5. Can y'all see that? So it's rotating left on T5. So this is my finger set up, and I come using the outer border, and I apply a PA, and this is what I get. So take a picture of this. So this is me applying my PA, all right, with the rule of the lower finger. So T4 is rotating to the left on T5. All right. So if I get a patient, right, and they're struggling with rotation to the left of the thoracolumbar spine, I can go through and assess that using this technique. I can actually assess it and see where segment is hypo, hyper, or whatever the case may be. Okay? So that is what that looks like. That's the rule of the lower finger with assessing and or treating mid-thoracic rotation via the transverse processes. So now, let's get a live patient up here. So the last patient I had, I was working through the shirt. Really, y'all supposed to work on the shirt. There you go. Okay, my right index finger is on her left transverse process of T6. My middle finger is on the right transverse process of T5. So if my index finger is on the left transverse process of T6, and my right middle finger is on the right transverse process of T5, and I apply my PA, what am I aiming to assess and or treat? Yep.
Yeah.
So rotation left of T5 on T6.
And we want to hear that whole spiel.
We surely do. We want to hear it.
What are you doing at what level?
Mm-hmm.
What on what?
What on what? And so now, only thing I got to do, I have my hand placement set up, right? I take the on the border of my hand and place it over my dummy fingers, and now I'm just applying a regular PA. But with that PA is emphasizing rotation of T5 on T6 to the left. All right? I can switch sides and do it to the right as well. How you feeling?
That don't feel good.
It doesn't feel good. She needs some mobility. So she's an interesting. She said it doesn't feel good, and I can assess this. I assessed and I'm treating, so I can assess this at each level. Okay. Now, like Dr. McClure said, you can come right here, like so, and get your hands, make your hand more relaxed. So I've been practicing for a while, so I'm used to getting my hand to relax and not so much tension because I've been practicing and doing this for a long time. So I can get my right hand to relax. But for novel therapists, you may have different time and you come right here to get your hand to relax more. But I'm gonna come right here, so I'm kind of used to relaxing my hand and not using it. Got it to a grade 4. Now, when I have you up here, I let you all see how it feels for me to practice with oscillations. So you can you feel I'm oscillating between grade 3 and 4? I can come back up some more and oscillate between 2 and 3. Or I can release and oscillate 1 and 2. Same concept as the extremities, you all. All right, now, somebody pointed out something earlier. It was Mason pointed out something about Kendall. So Kendall was trying to generate a thrust, trying to perform a thrust. And so when she got to end range, she backed off of it and then she tried to thrust. So take a deep breath in for me.
I don't know. I'm a little nervy.
You'll be fine.
All right.
What's your favorite cartoon?
I don't know. I can't think of one right now.
You don't have a favorite cartoon?
Hey, can I adjust this real quick?
Go ahead.
Okay.
Adjust it down just a touch.
There you go.
I
Then
can't-
blow out
oh,
nice and slow.
Maybe Leonardo?
Blow out nice and slow.
Well, they named after artists.
I think so.
There we go.
Okay.
So all the time you may not hear a release or you may not hear a pop or every time, but it's still achieved. But that was the thrust at the end.
Did you feel?
Assess another segment, but I can tend to go up and down, assessing her mid-thoracic spine with thoracic rotation via the transverse processes. So like Dr. McClure said earlier, with the PAs of the thoracic spine, especially the mid-thoracic spine, this is a good place to start practicing to get a feel for those different grades, to get a feel for hyper or hypomobility. This is a good place to practice. Now, why do you want to assess each segment? Some segments can be hypermobile, some can be hypomobile. Typically, when you have a hypomobile segment, a segment above or a few segments above can be hyper. Why is that? So now the patient's overcompensating at a particular segment to achieve the movement. So now another segment is overcompensating. And so now you don't treat that segment. That's why you go segment by segment. You don't treat that segment that's hypermobile with a thrust, or it may not even need mobilizing. It's already hypermobile. So now you have to know how to go segment by segment for that reason. Does that make sense? Because you just don't want to get a patient, if you haven't assessed them, you don't want to get a patient say, oh, I'm just going to go all the way down doing thrust. That may not be indicated. That's why the assessment of segment by segment is important. You see? So